You're live.
All right, we're live. This is Senate Health and Welfare. It's February 11th and it's Recovery Day in the State House. So at 9:45, we're going to have a joint meeting with House Human Services and listen to some of the recovery testimony that relates to one of our bills, S-157. But right now, we're going to hear from Katie on H-237 and look at what we have for that bill. And before we do that, I'm going to say welcome to our two medical student guests. Thanks for being here.
Thank you.
And why don't you introduce yourselves?
My name is Kim, and I'm going into radiology.
And my name is Lena. I'm going into OBGYN.
Okay. Maybe you'll be in Vermont. All right. I know you've been working hard outside the committee on this bill and communicating with people. Really appreciate that.
No problem. Katie McGlynn, Office of Legislative Counsel. So I know the committee has had multiple requests for proposed changes. And at this point, my instructions have been to sort of wait and have the committee hear those proposals before they're integrated into a draft.
Yes.
So we could look through the bill as introduced.
Yeah.
There was one small amendment that had been asked to, start in a strike all. We could look at that. Or you could look at some of the language you're getting from other folks. Where would you like to start?
Let's start with what we have in the bill.
Okay.
And the strike all. And then I know that VMS had some comments and I know OPR had comments back. And I know that the psychologists are here in the room. So maybe we can get into that level of completion on the bill.
Okay.
Because we're ready to finish the bill.
So I'm going to pull up a draft amendment that has one small change that was, I believe, requested by VMS. And then you have other changes that have been requested. Okay. So here is a strike all amendment. This is mostly reflecting the bill as introduced. We have our chapter on psychology. You have a definition section, and this is adding definitions of collaborating practitioners, the person who's working with the prescribing doctoral level psychologist. You have definitions of drug DSM, prescribing psychologist, and prescription drug and prescriptive authority as related to prescribing psychologists. Do you want to go over any of those definitions more slowly or kind of? No. Okay. In section 2, you have the powers and duties of the board, and there are some changes here. First, a strike through on the duty to explain complaint and appeal procedures to licensees' applications in the public, and then new language around regulate prescribing psychologist licenses pursuant to 3019, which is a section further on in the bill specific to prescribing doctoral level psychologists, including the settings of clinical rotations. Here is the proposed addition: the minimum requirements for the curriculum of a designated postdoctoral psychopharmacology program and prescriptive authority, including the designation of conditions and drugs excluded from that authority, as well as requirements for the prescribing of particular drugs.
So the question is, where did this language come from?
I believe this language came from Stephanie. Yeah, Stephanie Winters.
So this is VMS language. Okay, let's go through it all and then we'll come back and we'll open up for comments from folks around the room. We won't bring you into the witness chair, but we'll have a discussion about what's here. First of all, let me ask a question of, I don't know whether it's VMS, the psychologist, or OPR. And I'll go back to that one first change, but that's that. What are the minimum requirements of the designated postdoctoral psychopharmacology program?
I can answer that.
Okay,
The minimum
for
requirement,
the record,
for the record, my name is Dr. Rick Barnett with the Vermont Psychological Association. Thank you. The American Psychological Association has a very formal designation process for master's degrees of Masters of Science in Clinical Psychopharmacology. It's a designated 2-year master's degree in clinical psychopharmacology. That is what's in the bill. That's what's the requirement is. No one can get prescribing authority without going through that designated Masters of Science program.
so are you agreeing with this?
I don't understand what I would have to understand from VMS what they are changing here. It looks like, it looks consistent with, what we had before, so I'm not sure what was changed.
Okay, how is it different? Can we assess for you? How is this?
But this is new language. It's not replacing something else in the bill. So it's adding a new subdivision in the bill.
So then I'll turn to Stephanie for the record.
Stephanie Wichters, Deputy Director of the Vermont Medical Society. In looking at training programs across the United States, we did not see a standardized training or uniformity between all of them. Understanding that the American Psychological Association does have a list of training programs, we wanted to give OPR rulemaking authority to deem even above that, which met our Vermont standard of minimum training.
Okay, so then I turn to OPR. So this is about rulemaking for minimum requirements for psychopharmacology.
And we had intended to go through the rulemaking process for implementation of this chapter, so that could be part of the process.
Is it, so minimum requirements for, is it minimum requirements for,
It looks like 4 in the proposed.
I know, but grammatic.
Oh,
Grammatic. So the question,
Flag it.
okay, let's just flag that.
Okay.
But the question I will have you is how this fits with the rulemaking process. It seems psychopharmacology, as you said, it underlies what would be doing anyway. So it's how this fits in. All right, let's go.
I'm sitting here looking at this. I'm wondering about the word designated postdoctoral psychopharmacology program. Because I don't know if we use a designated
Why
program
don't we just take
elsewhere.
out undesignated?
Okay, let me take a closer look to see if we use designated anywhere else in the bill.
And does it have to be program? I'm just thinking it's the underlying content that's important. Anyway, thought there. We'll come back. to
Okay.
this.
And then last item on the rulemaking, it strikes out, explain how the board shall investigate suspected unprofessional conduct and instead have the language regulate collaborative practice agreements pursuant to section 3019 of this title, including collaborating practitioner qualifications and annual competency evaluations. So though that is all in sections of the chapter on psychology, within that chapter, section 3 creates a new section that is specific to prescribing by doctoral level psychologists. So in subsection A, there's the creation of a specialty that allows a psychologist doctorate to apply to the board for prescribing specialty. The application shall be made in a manner approved by the board with payment required fees. And subsection B allows for specialty by examination. So the psychologist doctorate shall be eligible for prescribing the specialty if that individual holds a current license to practice psychology at the doctoral level in Vermont if the person has successfully completed a postdoctoral training program in psychopharmacology, designated by the American Psychological Association or its successor. And 3, has completed clinical rotations over a total of not less than 14 months and not less than 9 practice settings, to include psychiatry, pediatrics, geriatrics, family medicine, internal medicine, emergency medicine, obstetrics and gynecology, surgery, and 1 elective. Completed national certifying exam as determined by rule and meets all other requirements for obtaining a prescribing psychologist specialty as determined by rule.
So one thing to think about is, we have the program here, psychopharmacology, and is this redundant with the rulemaking? So, maybe not, okay. Yeah.
One of the big questions that I keep seeing coming in from the medical field, and I'm not sure who answers this question, but do we feel confident that abiding by this section, which sort of sets the stage of training, meets that competency level for actually prescribing medication? Because that's one of the big questions that I've been bombarded with, and I just want to hear from the experts whether or not you believe the way this is written actually protects the public.
That's the question. So we'll look, I'm gonna look to OPR because they're the ones who have recommended this.
That's right, and we did a sunrise report on this psychologist prescribing scope expansion. And we think with this level of training, along with things like the collaborative practice agreement, that provides sufficient adequate training for prescribing psychologists to do this safely, and OPR supports it. So,
And there is oversight in here with the collaborative agreement.
yes.
And just wanted to follow up on that, because the other part of the question then, again, is just how many things we get sent to, and I know we've all been copied on these, is when you're dealing generally with your primary, they know all the different prescriptions that somebody is receiving and understand, you know, if I add something, how that interacts with the other prescriptions that that individual may be taking. And so how are we covered in that aspect? And so that when the psychologist basically prescribes, they understand what are the other medications that that patient might be under, and how what they're prescribing interacts with those other prescriptions.
And I think we have the answer to that, but I want to refer back to our report real quick.
Okay,
And then I can.
okay, so we'll keep going.
Great.
This is a question on the table. Go back. Okay,
Keep going. Okay. So next in subsection C, we have the actual criteria for prescribing medication. So that includes a written collaborative agreement for all prescribing psychologists who are practicing under a prescribing psychologist specialty issued pursuant to this session. So they have to have a collaborative agreement. And the second subdivision, the issuance of the prescriptive authority by a collaborating practitioner to a prescribing psychologist shall only include the prescription drugs for the treatment of mental health conditions that the collaborating practitioner themselves generally provides to patients in the normal course of practice. Third, the collaborating practitioner has to file a collaborative agreement with the board and any notice of termination of that agreement. And fourth, the issuance of prescribing authority for Schedule 2 through 5 controlled substances shall identify the specific controlled substance by brand name or generic name, and the prescription or administration of a controlled substance by injection is not to be allowed. Subsection D is the specialty by endorsement. The director of the board upon payment of a required fee, is to grant a prescribing specialty without examination if the applicant holds an active psychologist prescribing authority in another US or Canadian jurisdiction. And the requirements for psychologist prescribing authority in that jurisdiction are in the judgment of the director substantially equivalent to the requirements of this section.
Questions here? So part of the answer to your question is under the collaboration, where the collaborating physician or practitioner understands the.
People understands the overall.
I think, and I think given the training, that psychologists should also. I guess that was my question last week, that the psychologists didn't have access to the complete medical record. That right now, well, at least if you're in the UVM system, everybody knows everything. And it wasn't that long ago that they didn't know what practices within the same hospital were prescribing. But if you didn't know that this patient had kidney disease or liver disease or something, that's a bit that could be a problem. And I guess it's the timing. If the collaborative agreement says before the person goes out and takes this new med, that it's been seen by somebody who does have access. Or if you're going to give access. So we did hear testimony from the psychologists that they do look at the patient data records. We did hear that initially. But do they have, where do they get that information? They get it.
With the collaborative agreement, there's bound to be some rulemaking around, how information is shared between providers, and the primary care physician would not approve a psychologist prescribing without having shared those medical records. So whether it's through shared electronic health record, which is very possible, just needs some coordination, or it's through the old phone or fax or something. That's what's protective about it, is the collaborative agreement with the collaborative provider.
And Madam Chair, one thing also that I would add is when patients are obtaining prescriptions from pharmacies, those pharmacists, pharmacy professionals have also the entire kind of menu of drugs that the patient is on. And they are also doing like a drug utilization review so that they can also alert if there's potential drug interaction between multiple things that the patient's taking.
Okay. Oh, okay. I guess if it wasn't that long ago, we did pharmacy shopping. Yes, we did. If I get one prescription at Kitty's and the next prescription at Walgreens 2 towns over, is that a universal? No. They're saying, no, okay. So if I go to the same pharmacy, they know everything I'm on. But if I move around. I've been in Colchester this week and I go to the pharmacy and I get it. But that would be the case where the records that the physician and the psychologist are sharing would be important. I don't know that we can cover every single condition, because what you're talking about is it could be for any prescription. It's not simply related to this one.
Sounds like we're relying on the collaborative agreement.
Yeah.
Somebody with oversight over the overall condition of the patient, so that this is appropriate or not.
Yeah.
Yeah, well, I don't know who's the agreement with.
I see Katie pondering something.
No, I just got like an eye feeler. I think malicious activity block. I don't know. I think I have to get in touch with the IT department. I'm not sure what's happening.
Uh-oh, what's happened?
I don't know.
Frozen up.
Is it showing on that screen? No.
Yeah.
I'm gonna stop sharing and let you continue this conversation and I will contact IT.
What's happened?
I'm not,
We went through the whole bill, we read. Yeah.
We're almost on page 6 of 6.
we did get to the effective dates.
Right, which is the end of.
We changed the effective date.
I don't know if you want to change them. Yeah, so this updates them by 1 year because you had the bill, healthcare passed the bill out last year. So this has only been updated by year.
Are there any other proposals of amendments that we have had? I don't know.
Yes, you received proposals from OPR, you've received a proposal from DRM. So you have those to look through.
Okay.
Sorry. So 28 instead of 27, full making, is that what is a 2 year?
Yes. Okay, so OPR has a recommendation and DRM, are you representing the psychologist? So I don't know if they're different or the same.
The second, the second,
They're the same.
we can just go.
Let's go to OPR and look at that. We look at VMSs and we made some wordsmithing there. And I think we just leave that. And then, are you ready?
Sure.
All right. Why don't you come up? Presenting something.
I'm Jennifer Coleman, Director of the Office of Professional Regulation. Good morning. Let me just get it in order. Testimony from a couple of weeks ago that we filed on January 21st that had some proposed changes in it.
Yes, you did.
So I think very importantly, we would request that collaborating practitioner, that the definition include another prescribing provider as approved by the board. We have psych APRNs that are highly specialized in mental health care, and we want those folks to be allowed to be collaborating providers. And there may be others, I can't think of any off the top of my head, but there may be others that the board would want to designate who have that substantial mental health.
Do you have language for that?
Yes.
Can you, I know we have it, but can you share?
On screen. I don't have my I don't have a laptop.
Oh, you don't have
I'm
a
sorry.
laptop? Oh, I thought that was a laptop.
No,
Okay.
it's not.
So we have it, what was the date of that? And Calista, maybe you can pull it up.
I emailed that to Calista last night, but the date that we gave that to is January 21st, 2027.
So I have it right here. Well, we have,
Yes, sir.
we have it.
Use that if you want.
No, we-
You can't, me using impromptu
Well,
technology is
that's-
never a good idea. I really appreciate it.
We have it right here, so, or another prescribing provider as approved by the board.
That gets us back to the other question, which is, does that individual have the knowledge and ability to oversee the overall condition of the patient? Because we're talking about more than just mental health. We're talking about their overall physical health and how the prescriptions interact with the rest of their health. And so I want to be sure that collaboration occurs with somebody who has the knowledge, skills, background, and training to look at the overall health of the individual and how the prescriptions interact.
Absolutely, as do we. I mean, public protection is our mandate, so we would also be wanting to ensure that. So that would be part of the rulemaking process, and certainly OPR would put forward a rule that did not provide for someone who had OPR would not put forward a rule that would allow someone that did not have adequate training and expertise in education to be that collaborating provider.
So how do we say that? Or another prescribing provider with adequate, with equivalent training, blah, blah. How do we say that?
With adequate training and training, education and experience.
Equivalent training. I mean, it's up above, you have the primary care docs. And so,
Which can be an APR.
I know, I'm trying to figure out. Can you do this for us?
Yes, we'll work on language.
Can we get that?
Can I ask a question?
No.
Wow.
Okay, time zone. So as another prescribing provider is approved by the board, or isn't that assumed and approved by the board that they have adequate training? I mean, isn't, sure. So we're just like driving it home.
Yeah, we want to make sure they got the
Okay.
training.
Yes.
Yeah,
It's the belts and, I'm sorry, Lauren Lever, Deputy Secretary of State for the record. It's the belt and suspenders approach. It's the making sure it's in the statute and approved by the board in the rule. And I think we can work on the right language. I just want to be sensitive to the fact that probably there are some differences in training between psych APRNs and psychiatrists. So equivalent is maybe not the right word, but extensive, adequate. We'll work with everybody on the like.
Can we do that? Can we get that and work with Katie on that?
Yes.
And everybody else and his sister will have the. Okay.
And
Senator Hewlett.
thank you, Madam Chair. It also looks like adding this language is gonna change the effective date 29.
Yes, ma'am.
Okay,
So that we can do rulemaking
okay,
before we, in order to implement.
okay.
Okay. Oh, thank you.
Is that okay with all parties concerned? Yeah, okay.
You have section 3, you have some changes. And go into those or.
Yes, in section 3019, with the clinical rotations, we have worked with BPA and have agreed on 5 practice settings. We think that that would be adequate. There are some practice settings in here that really wouldn't pertain to who psychologists would be prescribing to. So the 5 practice settings and removal of some of those specific practice settings. Pediatrics, obstetrics and gynecology, surgery, and one elective. It looks like it's what we.
So we wouldn't be seeing a psychologist prescribing to a child or a minor.
That's correct. 18, anybody agrees?
Okay. Okay. And then there was the 29, Senator Pruitt just read that. 29, okay.
Well, it's not a full year. So, right, because we had it at 28, July 1, 28. So that's. Yeah.
Okay, so can we agree to put the changes in section 3 in? Can you do that? And then can we agree that we're going to have OPR recommend some language on the section 1 collaborating practitioner? Do that. So we get some equivalent knowledge base.
Can I ask a question? There are also effective dates in this proposal that are different from what we just looked at. That the remaining sections take effect January 1, 2029 instead
Right,
of.
we
Did
did
you
talk about
accept
that.
those? I'm sorry.
Yeah, we
I
did.
missed that.
We're
Okay,
good with it.
got it.
We're good with it.
Thank you.
Senator Hewlett's date.
Thank you. Any other questions?
No, this is good. You know, we hear testimony, we get the gist of what's going on, and then when we do markup, we have to go back and look carefully at what's in the bill, and that's what we're doing right now. This is helpful. Thank you. Okay. So what is the timeline on getting some language for us to look at?
15 or 20 minutes.
So in 15 or 20 minutes, we're going to be in room 10. So if you can get that to us, when we come back at 10:45, we are hearing testimony, but we'll try to sort out what that language is and then we'll put the bill into our hopper for final consideration. Good. All right, terrific.
Thank you.
Thank you all. This has been difficult, but good. I think we're in a good place right now. All right, so we are going to go off